my teachers, and all the respected guests from the city and out of the city with some bad experience, trouble yesterday as I came to know from the WhatsApp group. Thank you to the organizer for giving me this opportunity to share one case and our experience and the real scenario in the society. So, as a pediatric cardiologist, beyond pediatric heart, we also focus on fetal echocardiography, that is diagnosis of the baby's heart problem before the birth. And we get sometimes different cases, simple to complex, sometimes we able to understand or we not, but we counsel the family in the right pathway so that it becomes very easy for them to decide for their future and also future pregnancies. This is the small case summary. 20 years old lady from the remote part of the West Bengal, mid of Bengal, third gravida at 20 years of age. So you have to keep in mind. Gestation only 22nd weeks, and there is a significant past history. There is 2 babies with complex heart disease and both didn't survive. The obstetrician, they asked for the proper anomaly scan in the district level with possible fetal echocardiography, and by default they reached to us before doing the anomaly scan, and as the family knew, irrespective of their status, that last 2 babies didn't survive because of the heart problem. So when we put the ultrasound probe or echocardiography probe, the curvilinear probe for this type of activities, we have found there is some cardiac activity definitely present, but we could not properly classify or analyze. The heart was inside, not inside the fetus, but within the fluid, sac of fluid, amniotic fluid. So we try to understand little better with focused on the cardiac shadows or cardiac activities and try to understand that the heart outside the chest wall, and we could profile all the 4 chambers of the heart, and which is left atrium, left ventricle, right atrium, right ventricle, we could stamp on the screen. But this is not the end, but we made the diagnosis simple by more focusing on the 4 chamber views, the pattern of the orientation of the chambers with the great vessels. So it was obvious diagnosis, ectopia cordis. I don't know, I became very delighted because for a pediatric cardiologist, diagnosing ectopia cordis in utero before the birth, even before the PNDT permission, I think it's challenging for us who are working not in the metro cities or the capital, in the district peripheral level, and it was a good experience for me. But for a pediatric cardiologist or for a person who are expert in the echocardiography lab, only the crude or the basic diagnosis is not enough, because someone says they need more information, more profile, what's actually problem. So I try to give more stress on that. Before that, I searched in the literature and the article regarding the ectopia cordis. Its incidence is very low, like 5 to 8 per million of pregnancies. It can be classified into partial or complete ectopia cordis. It contributes only 0.1% of all congenital heart disease, and prognosis very, very bad. The 2 most important determining factor, there's a cardiac, apart from outside the chest wall, what is the intracardiac lesion, that is very crucial. And second, whether any extra cardiac problems associated or not. 90% of the patients with ectopia cordis, they are associated with congenital heart disease. Most common heart defect is the ventricular septal defect. Beyond that, ASD, TOF or pulmonary atresia, DORV or complete transposition may be associated. Apart from the heart, there may be some extra cardiac or some syndromic association which can be picked up by the expert or not, may not be possible. Like pentalogy of Cantrell syndrome, amniotic band syndrome, some defect like central defect, cleft lip, cleft palate, musculoskeletal system problem like kyphoscoliosis. These things can be associated. So when you are studying a heart in the bag of fluid, like a person who lost his direction in the mid of the sea, for a common people it's very difficult to direct from which direction where to go. But if the person is expert one, if you have the basic ideas of imaging, I think it may be also not too much difficult to reach the end or diagnose the problem. So if you focus here, the cardiac heart shadow is outside the cardiac thoracic cavity. I am able to see the chambers but not properly oriented here, all 4 chambers not clarified. But here you come, the still image from the cine we made, there is a left atrium, left ventricle, right atrium, right ventricle. How we give the nomenclature? So you have to see the offset of the atrioventricular valve. This valve leaflet is towards the apex. So possibly it is the tricuspid valve. From the basic fundas that the valve goes with the ventricle, not with the atria. And this is the left ventricle, rather smooth wall, and this is not that smooth. So that gave the idea. This is a classical 4 chamber. From classical 4 chamber, if you go either direction for or anterior or posterior, whatever you call. So if you lose the structures and is going towards one the septum, ventricular septum, there is a significant or very obvious dropout. That is the defect. That is the VSD, inlet VSD, and that this direction is just opposite to where I get the great arteries coming out from ventricle. I don't know which ventricle. We will give the nomenclature. Here you see the dual. There is the chambers. This is the right atrium, right ventricle, as I told, and there is 2 outflows coming out, which is seen in the same plane. So in a normal fetus or normal baby, great arteries cannot be in the single plane. That means it is a significant problem. If it's the same plane and parallel, that means we are dealing with a complex heart disease, and we are able to profile one of the great arteries branching. That means that is the pulmonary artery. And from the Doppler we have documented there is no significant flow acceleration. That gives the idea these outflows are not that much of obstructed or no obstruction there. So one ventricle which is in the different plane from the 4th chamber view, which gives rise to both the great arteries with the presence of some defect VSD at the inlet level. So most likely we are dealing a fetus with ectopia cordis with both the great artery from the right ventricle, that is double outlet right ventricle. So what's the complete diagnosis? So it's an ectopia cordis complete, double outlet right ventricle with inlet VSD, side by side great arteries and unobstructed outflow tract. And what we are talking about, a fetus at 22nd weeks of gestation. So that was the diagnosis. So from this short case presentation, not for the seniors, those are going to be cardiologists, those are going to be masters in the echocardiography. What I understood in my student life, we have to follow the basic rules. We cannot jump. So we need to understand basic few things. What is anterior movement? What structures we get? What is posterior? Which will be lost when you go to the posterior? Which will become at the first great artery from posterior to anterior? Second thing, we need to give nomenclature. It is not it's the left atrium, left ventricle, because on the left side. So there should be a proper connection, pulmonary venous to the atrium, that is the left atrium. Left ventricle is smooth wall. We have to focus on the atrioventricular valve, offset. And this is called segmental analysis. And after all this information, we need to assimilate to reach the diagnosis, and it helps actually yourself, myself, and also to the families. Thank you so much.